So for our next presentation, I would like to introduce Khoban Kochai. She is the Director for Anchor Institution Mission in the Office for Health Equity, Diversity, and Inclusions at UC Davis Health, presenting on barriers to accessing trauma treatment in Afghan refugees. So join me in welcoming her.
Thank you. Assalamu alaikum, everyone. Thank you for being here. I work in the Office for Health Equity, Diversity, and Inclusion, and here at UC Davis Health. And my primary role at UC Davis is better connecting and leveraging university resources towards the economic benefit of our surrounding communities. And that's in our Anchor Institution mission. So the Anchor Institution mission has been adopted for about 2 years now here at UC Davis Health. And has been actually included in the clinical strategic planning process this year for the medical center. And what that means is that the university is really taking an active interest and role beyond just providing access and quality of care to addressing the social determinants of health in our surrounding communities. I'm connected to this work in particular. I'm an Afghan refugee myself, and just wanted to share this today. I've been thinking a lot about this little girl. So that's me with my family in the early 80s. We came through in the first wave of refugees during the Soviet War. I don't know, I felt like today I was learning so much about myself and kind of going back and thinking about my own childhood experiences that I couldn't process, during that time. But now as an adult, kind of going back and looking through and thinking about those experiences has really, everything that we've learned today has really helped me, has really resonated with me. I think that, in this picture, you see a little girl with her family. This is probably about 6 months after we'd arrived in the United States. And, I think I look like a normal little girl smiling. But really what was happening is, I think I was, and I've always played this role in my family, been a very positive and sort of bubbly child to kind of support and take away the suffering maybe that I saw in my parents and in my family, but was already having like intense nightmares, like literally every night of going to sleep. So my memory starts about at this age, about 5 years old. But prior to that, as we were sort of in our immigration journey, was a very horrendous one. We had our home bombed in the middle of the night and had to escape. We lost a number of family members and trekked through Pakistan into Peshawar. But there's no memories for me of that time, even though I probably should be old enough to remember those things. My memories kind of start during that acculturation period. And so it just sort of makes me think about, again, that intergenerational trauma and how that persists over time. And now being a mother of 3 young children, really being cognizant of how I am thinking about trauma and kind of hopefully passing along some positive coping mechanisms, because no doubt I'm probably passing along some of that trauma as well. Today I'm going to be talking about barriers to treatment and to care for Afghan refugee families. I'm on the board for Opening Doors, which is a resettlement agency here in Sacramento. I'm also on the board of Shifa Community Clinic and have been working with them since I was an undergrad, so for many, many years now, and have stayed pretty well connected into work around the Afghan refugee populations. So I'd like to talk a little bit about economic barriers to social mobility for the Afghan community. We'll talk just about some of the barriers, and you've heard a lot about these things, but we'll get just into a little bit more detail around kind of physical and other stigma-related barriers to access for treatment, and then just close out with some promising approaches to maybe addressing some of those barriers to care. I'm not going to go through the background here because I think you all have gotten a lot kind of on context. Just one point that I'd like to kind of focus in on is recognizing, particularly in Sacramento, that different waves of refugees are going to have widely different experiences. So my wave of refugees, where my experience was very different. I came into rural Alabama, is where I grew up, where there was like no health services for anyone. We got most of our services at like the local, like Mike's Pharmacy. I actually literally do not recall ever going to the doctors. And so very different experiences depending on where you land and what that journey is like for you. So I think one group that we haven't quite talked about today, we talked about sort of special immigrant visas. We talked about folks that left in the most recent wave in August when the displacement in Afghanistan happened. Another kind of interesting group that has arisen out of all of this is folks that are moving into California, or coming into California from the southern border. So folks are finding ways to get visas into Central American countries, and then they trek, across the Central American pathway up through the U.S.-Mexico border. Folks travel through jungles. They literally climb over walls. They end up in our detention centers, and they're coming over with families. And so actually right now I'm hosting a family that went through that exact trek. It's a parents with 3 young children, and hearing their stories is incredible. They've gone through such a harrowing journey, but that journey is going to be different than coming over on a plane, right? I'm not saying that that the coming over on a plane was not difficult and those preconditions, but I think it's what the first speaker talked about pre, and then what happens during that migration process, and then what happens post. And so I think for this group and kind of for clinical providers, it's another thing for everyone to start thinking about, right? Like, what is that experience going to be like? And then those folks that come here are not going to have legal status. And so a significant difference is that SIV immigrants and, humanitarian paroles, or folks that come in actually seeking asylum, are going to have some sort of legal status. And so they're going to have more opportunities for work. They're going to have more opportunities for for earning income. What about, those that are coming in with absolutely no legal status? And so just another kind of complexity to all of this, I think that will be important for us to think about. I wanted to talk a little bit again about the social determinants of health. So we all know that access to care and quality of care are incredibly important, and institutions like UC Davis and hospital systems, do an okay job, but it's really only about 20% of your health is determined by access to care and quality of care. Another 40% is determined by social and economic factors. And so if those social and economic factors, for example, employment, you don't have a stable job, are not met, that's going to really impact on your health overall. And so it'll be important for us to think about like those types of economic indicators. And then I wanted to just touch here a little bit on the community health needs assessment. So every health institution every 3 years has to do something called a community health needs assessment, where they go in and they assess, the most important or most significant needs that are coming out of the people in their surrounding area. And what UC Davis, and remember where we are, we're in Sacramento. So in this, like in a periphery of like 10 miles, we have 4 health systems. We have UC Davis, we have Sutter, we have Dignity, and we have Kaiser. So it's 4 huge health systems, right? Kind of serving the same area. And what did those health systems learn are the most critical needs of their surrounding populations? Well, it's access to mental health, mental and behavioral health services. That is always at the very top. Exactly what we're talking about today. Access to basic needs such as housing, jobs, and food. So if you don't have access to those basic needs, are you thinking about your mental health? Are you thinking about your appointment that you missed? Are you thinking about, getting your child preventative care? No. And so it's critically important for health systems to think about policy and to think about how they're addressing those social needs. System navigation, I think all things that we're familiar with this year, and the community health needs assessment, they added this element of health equity. And what health equity includes in this community health needs assessment is they include cultural competency here, which is a really important one for Afghan refugee communities, right? And then also issues of racism and discrimination, which is, I think, something we haven't talked too much about today. You know, systemic and structural racism are at the core of inequities across all of our communities. And so it's going to be really important to be able to talk about systemic racism, discrimination, and bias against Muslims in the context of equity and in the context of getting access to care, because that's all a part of it, right? And we can't ignore that. And then, this outlines, again, out of the community health needs assessment, our communities of concern. So the areas in yellow are all communities that have the highest rates of poverty, that have the highest rates of unemployment, the lowest rates of education, and so forth. And so those are identified as communities of concern. And again, I just wanted to put the map up because it shows you where all the hospital systems are, right? So again, it's not just about being close to a medical facility. It's about finding ways to open the doors of those medical facilities so people know how to enter them and can do it in a way where they're getting culturally competent care. And then the other thing I think that this highlights, and I wanted to talk about the community health needs assessment, is that refugee populations are coming into an already stressed system. So all of these issues exist in the Sacramento area for many, many years, right? And it's an ongoing issue. And so refugees are coming into an already stressed system, into a system that's not quite doing what it's supposed to be doing, right? Because we have all of these social inequities happening in the Sacramento area. And so, again, how are our systems going to adapt to really provide the kind of care that these even further vulnerable and traumatized communities really need? So some economic considerations when it comes to the Afghan refugee community. A lot of folks coming in, particularly SIV holders and humanitarian parole recipients, are eligible for federal public benefits, which is a good thing. So, they're eligible for medical services and so on. But are they accessing those services? We want to think about food security. Food security is not just about being able to go and, purchase food on your EBT card or on your SNAP card at a grocery store. It's about really understanding the nutritional value of food and being able to find culturally appropriate food that makes sense for your family. And so if you go to, for example, food banks that are giving out food, during COVID-19 and these times, you often don't find culturally appropriate food. So folks will take them home because, they need the food, but are they going to use them? They don't know how to use, a lot of the stuff that they're getting. And so what are ways that we can really think about kind of making food more accessible and making food more nutritionally valuable to the communities that need them the most? Folks are entering into niche jobs coming in from the refugee community. So a lot of SIV holders, particularly men in the community, enter into jobs like Uber, security, food delivery, or into other entrepreneurial activities. But there's not necessarily stability in those jobs, and so we're not, our refugee communities aren't entering into jobs that are going to provide long-term, stable incomes for their families. And they're aware of this, and that's like a huge stress and a huge barrier to upward mobility for our communities. Women in our refugee communities and the Afghan refugee community have some of the lowest rates of unemployment, regardless of how long they've been in the U.S. And so, we talked about large families coming through. And so women, are taking on the burden of becoming homemakers and taking care of those large families. What that, something to think about in that space is what that means is women aren't out in the community as much. They're primarily in the home, and so that can cause social isolation. And so what are the ways that we're thinking about reaching into those families and reaching those women to make sure that they're getting their needs served? And we talked about a lack of viable career pathways. Workforce development is a huge area of funding right now from state and city levels. There's a lot of money being invested in workforce development efforts. What are the ways that institutions, CBOs, and local organizations are trying to take advantage of those funding opportunities to focus on refugee communities and to focus on the Afghan community in particular? And then finally, I think we talked about this earlier, kind of post-migration stress of the financial burden for refugee communities to give back to their families back home. And so Afghans have one of the highest levels of remittance back to their home country. And so when they're often coming here, they're not coming here just to support themselves and their immediate family members. They're going to be supporting at least one other family back home. And that's an every month sum that's going back. And so, when kind of considering economics, it's important to remember that, it's going to be very rare, I think, the case where you find an Afghan family here that's not somehow sending support back home. And so another huge financial stress and burden. We talk a lot about language. Language is, I have a quote here, it's a gateway to everything, to being able to help your children succeed in school, to being able to navigate the different social systems, to build community and get a job. If you don't have the language, it creates it's probably the biggest deterrent. I think it is the biggest deterrent to adjustment for refugees. And so some of the ways that we the barriers more specifically related to language that we hear about is a lack of interpreters in the appropriate dialect. And so if you go into a healthcare system and they you say you speak Farsi, you're often going to get an Iranian, a person from Iran that speaks Farsi, but it's not the same dialect. So most Afghans speak Dari. And so they're not going to be able to get that same level of treatment because it's the wrong dialect. Usually at clinics, they'll either have a Dari speaker or a Pashto speaker and not both. But the Afghan community, Dari and Pashto are in equal numbers probably here. And Pashtuns don't always speak Dari, and Dari speakers don't always speak Pashto. And so it's important to think about, when you're thinking about interpreters, thinking about the dialect of those interpreters. Females going into healthcare systems want female interpreters. Whether they say that to you or not, they want female interpreters, and it's going to make their experience better. You're going to be able to get more from that patient if there is a female interpreter in the room. It should almost not be asked, but I know there's limited resources. And so that's something that comes across quite often. And men usually like male interpreters, and so having that gender match for interpretation is important. Interpreters with health literacy. And so, we talk a little bit about the low health literacy in the Afghan community. That isn't always necessarily different for interpreters. And so really thinking about making sure that the interpreters are competent to provide the type of interpreting that you need is an important element. And then another kind of piece of the language is communication, right? And so it's not just about interpreting, it's really about rapport. And so how are physicians building rapport with their patients? One thing that I often hear is kind of the American style of providing care is very cold and unwelcoming. You sort of walk into a room, what's going on? Okay, what's your problem today? There's no greeting, there's no welcome. We always say "Staremase" or "Assalamu alaikum," welcome to my space. There's some form of greeting, and when there's a lack of kind of that rapport building, it makes it more difficult to have trust. And to kind of build a relationship. And so that's something really important for our clinical providers to think about, rapport. System navigation, again, we talk about this quite a bit as well. You just imagine, I think everyone here probably has tried to make an appointment through their healthcare provider. Well, imagine trying to do that without knowing all the right people to call, without having the right language, without knowing how to navigate the system. And so I think everyone can acknowledge how difficult that may be. Transportation, just wanted to touch on that really quick. Transportation is a huge barrier, especially for larger families. And so you have families, coming through that might not all fit in one car. Coming in for appointments is difficult when you have 5 children to bring in, right, at different points in time. And so really thinking about how you're scheduling appointments. Is it possible to get the family in maybe into one setting, or kind of being a little bit more innovative to think about childcare and transportation issues for families and how hard it is for them to physically get to appointments. Trust and bias. So generally, I think we talked about this earlier too. There's a lack of trust in healthcare institutions, and some of this stems from experiences in Afghanistan, where it's a hugely under-resourced developing country, right? They lack basic infrastructure. There's been war for over 40 years. And of course, that's going to play out in the healthcare system, right? And so what you have is sometimes incompetent medical providers that people don't trust going to. And so you're kind of coming in with that context, is there's sort of already a lack of trust in healthcare providers from the home country. There's also, we talk about cultural humility, a lack of kind of cultural humble care, right? So respect for modesty, for example, and cultural needs. So really understanding that if you have a female patient in the room, having 5 other residents hovering about as she's talking about her reproductive issues might not be the best idea, and so just kind of being more attuned to the cultural needs, especially for women, around modesty, and where a woman is going to feel more comfortable talking about to her clinical provider. She'll also, building that trust out will make her more accessible, make a child more accessible to you. If she trusts her provider with her own care, she's going to be more likely to trust that provider with her child's care. But women in this community are very protective of their children. If they don't trust providers with their own care and believe that they're culturally sensitive to their needs, they're not going to trust you with their child's care. And so if that child is even experiencing trauma, you're certainly not going to hear about it, because she's not, she doesn't feel like you're tuned into her care even. There's a huge fear of losing their children to Child Protective Services. So this is a reality, right? This has happened where Child Protective Services has sort of come in and saved a child from a household. And of course, sometimes it's issues of domestic violence and, bad things are happening in the household, but those stories spread really, really fast. And so you're going to come in with families that are really, really highly suspicious of the healthcare system, because they're seeing healthcare systems as conduits for removing their children from their care, which is possibly the worst possible fear for a family, right, of a family being broken up. And so there's a huge fear of that happening, and something, really important that we need to think about as well. Discrimination, I talked about this a little bit earlier. This community reports that they experience high rates of discrimination when they reach the United States, and much higher rates compared to other Asian groups. And so there was a study done, the measure of discrimination, talked about unfair treatment and marginalization of Afghans. And again, the Afghans reported to have kind of the highest levels of discrimination in those areas. There's a few, sort of socio-political things in the country that attribute to that. So, there's the rise of xenophobia and anti-foreign prejudice, with the Trump administration, and kind of that experience of the other, very clearly placing Muslims in that other group, right, of othering them. And so that bias seeps into our healthcare systems, whether we want it to or not. It's going to seep in to our providers. It's going to seep into our systems. And so what are the ways that we're addressing bias and really helping providers to think about unconscious bias, as well as kind of openly explicit systemic racism and so on? The other things, again, with the Muslim faith, especially after 9/11. And so 9/11 is going to be with us forever. That's never going to go away, right? And so my nieces and nephews are first generation Afghans, and they were in their adolescent and kind of early years right after 9/11 happened. And they had teachers, calling them out in class, calling them terrorists, as a joke. And they had, students picking on them and being like, oh, are you going to blow yourself up? Or why don't you, was your cousin's name Osama? These types of ridiculous things, right? That sticks with you. And my nephews to this day remember those experiences, and it has really formed them into the people that they are now. And so, the political climate that was created after 9/11 is always going to be connected to the Muslim faith, unfortunately, but it's something really important for us to think about as clinical providers and as service providers to this community of how we're addressing that. And then, recently more of the kind of tumultuous events happening in Afghanistan. The United States occupied Afghanistan for 2 decades, and then decided to pull out right away, right? So trust building. And so as nice as Afghans are coming into you for care or coming in for services, they're gonna, that's in the back of their heads that these are the same people that turned on us in our moment of dire need, okay? And so, I hear that a lot in focus groups. I hear that a lot from community members out there. So it's important to frame that and have that context. Stigma. So stigma is a huge barrier to care. Mental health is often it's a very taboo topic. We don't talk about it. We almost don't have those idioms of care. That was so interesting. I didn't know we had terms for it, but apparently we do. And so maybe it's about educating the Afghan community to better understand the ways that we can talk about it. But for the most part, if you're out seeking mental health services, you're sometimes thought of as crazy or weak. There's a fear of consequences, we talked about earlier, of admitting that you might have a mental health need, or that your child might have a mental health need, a fear of repercussions, losing your job, and even losing your child. And then there's also this need to not burden others. This is your problem. This is yours to deal with. This is yours to grow from. And so not wanting to give that to others, and almost also wanting to protect your dignity and your vulnerability in that problem. So when someone has lived a life of survival, vulnerability is the last thing you're going to portray, because most Afghan refugees are perpetually in that state of survival. And so they're not going to want to talk about their weaknesses. They're not going to want to bring those things to light, because it's very difficult to deal with and might give off the wrong perceptions. Just really quick, some approaches. We talked earlier about focusing in on the schools. Are there opportunities to better collaborate? Provider systems, like I said, we have some of the largest healthcare provider systems in the area in Sacramento. Can we better partner with our school districts to do more programming, to apply for more funding, and to get out programs that are really going to address the needs of these groups? Cultural competent care, so offering bias awareness and cultural community training to clinical providers and the staff. Everyone needs to have a good awareness and understanding of their bias, and so they're able to really kind of bring that to the forefront when they're thinking through their work. Partnership and coalition building. And so I think this is another area, particularly in Sacramento, that'll be really important. Our office has recently taken the lead on creating a refugee health coalition. And so that's bringing together providers and soon community members to really think about refugee health across the Sacramento area, to think about the needs of clinical providers in serving this community, as well as the needs of the community themselves. And so what are the ways that you're partnering with other CBOs, with other organizations, and with other health systems to kind of coalition build, network, and learn from each other? And then finally, I think the one that I'll talk about here is research and funding. We need more research in this area. How do we get, how can we advocate for this community? Okay, how can we get our scholars and researchers to do more research so there's more data so that we have more to talk about when we're out there trying to get funding? How can we better connect with other organizations at the international level that are maybe doing this work to bring more attention to this cause? And then policy, legislation, it's huge. You know, we are in Sacramento, the capital of California, right? We have to try to figure out ways to be better advocates for the Afghan refugee community so that that funding comes through and those programmatic changes come through. And then these are just resources. I'm going to leave them in my slide set for anyone that's interested. Thank you. I think maybe a minute for questions. And that's my contact information if anyone is interested in getting in touch. Thank you.
Well, thank you so much, Khoban. It was so comprehensive, from discrimination to literacy. It was all-inclusive. And to Khoban's point, you know, when I was growing up as a physician in North Afghanistan, I was thinking I will become a doctor, I will train, I will help build a hospital, and that's how we will make people healthy. But when I became a physician, I noticed that, as Khoban was saying, it's 15 to 20% the hospital that makes us healthy, but 80% the environment. Where we live, how much we know, what we eat, our education, our neighborhood, transportation, everything makes us healthy versus sick. So that was so comprehensive. Thank you so much. I know we are a few minutes over time, but I'm going to still have one question. Okay, Mr. John, please go ahead.
Thank you very much, Mr. Khoban. Nice meeting you. You mentioned very good points from the heart of refugee community. And also, there are some facts that we health community, health institutions need trust building among the patients and also the community. Because some of the myths that we have here is refugees do not want to share their mental health issue. Being it's recorded, they will not find a job if they mention that I have stress, if they mention that I have anxiety, insomnia, all these issues. So, however, there are others who are telling them that, you know, doctors have are private institutions. They are not going to share. They are not police. They are not. But they heard of like mandatory reporters and these kind of things. So, such kind of things need to be addressed in our report. Thank you.
That's an excellent point. And those are things that clinical providers can work into their primary care visit almost, you know, better explaining HIPAA guidelines and what that means, better explaining the rights of patients, and maybe training interpreters to be able to talk about that in a way that folks are understanding and where we can do some of that myth busting, like you said. So excellent point.
Yeah. Thank you so much.